Hello, my name is Erin McDonough, and I will be presenting on risk factors and prevalence of food insecurity in an urban emergency department. This is a study I worked on with fellow medical students Karen Collins and Rebecca Breed under the guidance of Dr. Goyal and with the assistance of Dr. Becker for statistical analysis. I have no relevant financial disclosures. 49 million people in the US are food insecure, meaning they are concerned about where their next meal is coming from or how they're going to pay for groceries. The national estimate for food insecurity is 11.1%, and the regional estimate, where I am in DC, is a little higher at 14.5%. Food insecurity is associated with numerous poor health outcomes. In a previous study done by another medical student, we found that at our hospital, 46% of the hyperglycemic patients were food insecure. This got us thinking that food insecurity may be more prevalent in the ED than it is in the larger population. We know that only 56% of those who are food insecure nationally participate in one of the three major national food programs. So this means that ED clinicians may in fact be very well positioned to address food insecurity in their patients if they can identify them. So the objectives of our study were to quantify the prevalence of food insecurity in heterogeneous emergency department population, look for associated factors to help develop a screening tool, and then identify potential interventions that are feasible in the emergency department settings. This was a single-center prospective observational study done in our urban adult tertiary emergency department, about 90,000 patients annually. The study was done over 25 consecutive weekdays, November through December of this past year, 8 a.m. to 8 p.m., because that is when our social workers are in the emergency department. We approached all medically stable adult patients, excluding those who could not reliably be consented, which was largely non-English speaking patients, as well as patients with altered mental status. We interviewed consenting patients and then did a multinomial logistic regression model, which explored food insecurity and which variables may be potential predictors. The survey itself consisted of a validated two-question screening tool. We worried whether our food would run out before we got money to buy more, and the food that we bought just didn't last, and we didn't have money to get more. If patients answered often true or sometimes true to either of these statements, then they were considered to be food insecure. We then asked them some questions about what resources they might be using in the community, as well as a variety of socioeconomic factors listed here. We then pulled some information from their medical records, included vital signs, glucose level to follow up on that previous study of hyperglycemic patients, as well as BMI, pre-existing comorbid conditions and associated medication use, history of substance use, domestic concern screening, mode of arrival to the ED, and their final disposition. We approached 1,240 patients and had a 55% participation rate. Of the 683 patients who did participate, 240 screened positive. So that's 35.1% of the patients we interviewed were food insecure. Looking at our general demographics, we do have a large African American population. The majority of our patients are either employed or retired, and we did talk to more female than male patients. We also do have a very significant population who are living at or below the poverty line, which is 25,000. So for patients who reported often true to worrying about lapses in their food supply, we found that they were 7.4 times more likely to have to choose between buying food and buying prescription medication, 6.7 times more likely to report a race other than white, 4.6 times more likely to be employed full-time, 3.5% more likely to have a household income at or below the poverty level, 2.7% more likely to be female, and 2.5% more likely to have a history of substance use. Some limitations of our study were that we were unable to assess non-English speaking patients and that we were only doing sort of workday hours, so patients who work full-time, we may have been missing some of those patients. Additionally, a majority of the surveys were completed verbally via a research assistant. This was to limit any problems with literacy, but may have led patients to be less honest with us. Some confounders, looking at that higher odds ratio of female, It should be noted that all data collection was carried out by women, and that many of the male patients, in fact, noted that they did not manage the food resources in their household. Finally, we did have limited patient follow-up. So we did provide resources to all the patients in our ED who were food insecure and sent them a follow-up survey via text asking essentially if those resources had been at all helpful to them. Of the 240 patients, only 4 responded. So obviously that was not enough to assess the efficacy of our intervention. In conclusion, 35.1% of stable adults in our single inner-city emergency department reported food insecurity. This is much higher than the national or regional estimates, and notable associated socioeconomic factors were identified as race, gender, and history of substance use. Our next steps would be to develop an electronic tool to ID at-risk patients, and then to assess the efficacy of providing community resources or interventions in the emergency department.